and virtually certain some of you know him already. He is Dr. Greg Lester. He's a licensed clinical and consulting psychologist. He's held membership on the graduate faculty of the University of St. Thomas, is on the continuing education faculty of cross-country education, and is senior research director with the Improvement Research Group. Greg's talk, our presentation today, is entitled "The Difficult Client, Talking to Those Who Can't Listen." So with that, I turn it over to you, Dr. Lester.
All right, thanks very much, Dan. I appreciate it. All right, hello, everyone. Welcome. It's nice to be with you. I've missed being with you guys since we didn't have the AHI last year, and I've tried to come in previous years. So I've had to cancel a couple of times. My travel schedule got a little crazy. I was traveling about 40 weeks a year, and so I had to cut back. So first thing I want to note is I am not one of you. I do not run a crisis pregnancy center, etc. I'm a psychologist. But my specialty is one that is a little odd. There are only about 6 people in the world who teach this. And it is one that cuts across all areas of both mental health and, believe it or not, ministry. There was a study done by the University of Hawaii in conjunction with Loyola in Chicago that found that ministers see more people with diagnosable mental health conditions than all mental health clinicians combined. And I consider you guys to be a combination of ministry and clinical. So you see a lot of what I'm going to describe today. In fact, the data show that the thing we call a personality disorder is the most common mental health condition. Also the least understood, but even by most mental health clinicians. The data show, and we've done studies all over the world, North and South America, Australia, New Zealand, Scandinavia, Southern Europe, Western Europe, Romania, Japan, China, South Korea, Taiwan, Zambia. And all of those studies show that somewhere between 15 and 19% of people have lives that are harmed in the way I'll be describing. And in clinical population, people like you see in crisis, somewhere between 39 and 100% of your clientele will present with these conditions. Now, the reason you should care about that, and the reason I'm here, I always think it's the first thing speakers tell you is why you should bother listening, is these people don't listen like you and I do. These people do not have the psychological equipment to be able to have the kind of conversations that you and I have with each other that make an impact. And what we've found we now have 60 years of research on this population, is that there are specific ways you can think about them and specific methods you can add to how you talk to them to double your impact, increase it by like 100%. You know, 60 years ago, we couldn't say that. 60 years ago, the lore was, forget them. You can't help these people. There's nothing we can do to make a difference. These conditions are permanent. Well, fortunately, we have so much data now that that is not true anymore. One of our gurus in the field was a psychiatrist who unfortunately passed away a few years ago at Harvard named John Gunderson. And it was one of the engineers of getting personality disorders listed in the diagnostic manual back in 1980. And in one of his final books, he says, we know so much about helping this population that we can now ethically say to these clients, yes, I can help you. So let me tell you what we're going to do today, because I work a lot with crisis pregnancy groups. I've worked with you guys. I spoke at Catholic, I was the keynote speaker at Catholic Charities annual conference one year. I'll be doing 2 days in October for the Texas Crisis Pregnancy Network, et cetera. So I am familiar with the clientele you see, with what you have to, what you're up against and what you do. So what I'm going to do today is focus what we have found in the personality disorder area works for you to apply in your context, in your situation with your clientele. Now, to do that, I'm going to have to do a couple of things. And I want you to know this is a crash course. My most basic course on personality disorders is 6 hours long, and my fundamental course is 18 hours long. I now have about 45 minutes with you. So let me tell you what we're going to do. First, I'm going to tell you how we came to see this so you know what the terminology means. Then I will show you what a personality disorder is. There's a graphic that describes it so you can see why this population, people who come to you in a crisis pregnancy situation who have a pre-existing personality disorder are coming to you missing important psychological pieces. And if you try to have a normal conversation with them, it's not going to happen. So I'll show you what it looks like. It's not complicated. You'll be able to get it. Then I'm going to give you half a dozen techniques drawn from our literature that we have found are kind of the most powerful in making an impact. I'm not going to ask you to change everything you do. I'm going to give you some things to add on and some methods to adjust what you do to have an impact. Now, those aren't going to hurt anybody. So you don't, if someone isn't personality disorder and you do the things I'm going to tell you to do, you're not going to hurt them. It's going to be fine. It just isn't going to make that much difference, but it makes a difference with this population. So, you know, you and I overlap and we're in the same business of saving lives. You know, you save them one way, I save them another way, because the personality disorder diagnosis increases suicide risk by 700%. Borderline disordered people have a suicide rate 400 times the general population and 800 times the population of women childbearing years. So we're in the same business in that sense. So having an impact for you and for me is paramount. So let me tell you how we came to see this, you guys, real quick. You got to understand that mental health is a new science. You know, I am not a minister, I'm a scientist. I call myself a mechanic of the mind. And our science started only about 100 years ago, and the first condition identified as psychiatric. And what I'm going to use occasionally, you guys, is a whiteboard. I'm going to write on it. So forgive the crude nature of my graphics, but we found that PowerPoints kind of freeze people's brains. So the first condition, you've heard this term that was ever coined for a mental health condition in the early 1900s was a thing called psychotic. Now that term literally means misperception of consensual reality. What it means is the reason someone's life doesn't work is they see and hear things. That's all it means. It doesn't tell you why. It's called descriptive pathology. So the first condition ever identified as a mental health condition that damaged people's lives and kept them from living good lives with the thing called psychotic. That term was coined by a neurologist named Emil Kraepelin. And you know, people who hear voices, who have hallucinations, have delusions, very severe psychiatric symptoms. So we identified that early on as a thing, as a condition. It's consistent across the world. It's as consistent as pneumonia or anything else. We didn't know what in the world to do with it. So the answer was they couldn't function in society. We put them into asylums. We warehoused them. And it was a sad era, you guys. They were not good places. The first asylum in England was in a town called Bedlam. That's why the phrase became something's total bedlam, because it was lousy. Along came another neurologist in the 1920s who noticed there were other people whose lives that didn't work well, but they weren't, quote, crazy. They didn't see and hear things, but they had emotional reactions that were inappropriate to the situation. They were depressed and nothing was wrong. They were panicky and nothing was dangerous. They were anxious and nothing was threatening to them. So they didn't misperceive reality, but they had emotional reactions that were inappropriate to the situation. You know, if you have upset feelings that are appropriate, that's in normal limits. Like regrettably, about 10 days ago, Pam and I lost our little kitty cat of 13 years, Mingo. You know, I cried over him for 3 straight days. And you know what? That was appropriate. Loved him. He slept with us every night. He was a wonderful old pet. So, I boohooed. But you know what? If someone's crying all day, every day in normal life, that's inappropriate. That's something wrong. So he gave a name to people who have emotional reactions that didn't fit the situation. To contrast it to psychotic, he called it being neurotic. And you've heard that term, right? All neurotic means is inappropriate internal distress. It means that your emotional state is inappropriate to the situation. Now, the neurologist who came up with this term, you might have heard of, his name was Sigmund Freud. And he said, I actually think we can fix these people. And so his conclusion is that the reason people are having inappropriate emotional reactions is that they had an emotional reaction that was appropriate a long time ago to something. They were abused, and so of course they were upset. They were abandoned, so of course they were upset. And what happened was that upset from that event never went away. So he developed a way to go back in time to find out where it started in order to resolve it. And he developed a model that you've heard of called psychoanalysis. And the job of psychoanalysis is to review back to your life to find out, where did this bad feeling start? What was it that happened that made you feel this way? And then an analytic process is a psychological process designed to disconnect you from that, to get that not to run you. And then that fades and you have emotional reactions appropriate to the current era. Pretty intelligent, actually. Psychoanalysis gets a lot of contentious humor, thank you, Woody Allen, but it's a pretty good model for doing that. But here was the problem. We had two conditions. We had psychotic people who we were locking up because they couldn't function in society, and neurotic people who were doing psychoanalysis with to unhook them from old bad feelings. Well, here was the problem. Come along 1950, we found that there were people who didn't fit either one of these things. They weren't, quote, crazy and doing bizarre and sometimes bad things, so we didn't lock them up, but psychoanalysis failed with them. And all this going back in their life to their childhood went nowhere. In fact, some of them, it actually made them worse. So what happened was we realized that there were some people who had lives that were in trouble, who were behaving badly, who were experiencing distress, causing trouble for themselves and others, even like psychotic people do, but they didn't fit psychosis and they didn't fit neurosis. Psychoanalysis didn't work and we shouldn't lock them up. And we didn't know what to do. So in the 1970s, the American Psychiatric Association said, hey, we have to redo our science. So we have a way to think about these people we're not helping and we don't understand. So they put a very famous committee together called the DSM-3 committee. And the committee sat down with the science and looked at it and said, it just doesn't work. We're going to start over. So they, through the previous manuals, one was published in 1952 and one in 1968 in the trash, and said, we're going to redo mental health in a way that encompasses all the people that we're trying to help and don't. And they said, here's how we're going to do it. We're going to do it by what things look like. And some people psychologically malfunction in a way that looks like is the psychological version of a thing called an illness. It resembles an illness only in the area of mental health. And the reason it resembles an illness is it has symptoms. Things like depression, things like anxiety, things like attention deficit, things like addiction. And those symptoms work very similarly to how physical illnesses work because they run a predictable and reliable course. You know, COVID runs a course. A head cold runs a course. The flu runs a course. Well, so does depression. So do panic attacks. So do psychotic episodes. So do manic episodes. And so when you look at people who have trouble psychologically in some ways, some of them look like they have the mental health version of the thing we think of as an illness. So they said, we're going to call stuff like that psychiatric illnesses because they look like illnesses. And we're going to put them in a diagnostic category. We called it Axis 1, and we're going to give them names that are for the symptoms: depression, major depressive episode, bipolar, dysthymia, anxiety, generalized anxiety, phobia, panic, social. We're going to keep the term psychotic because that is symptom. And we're going to put in other names like attention deficit and addiction, all symptomatic conditions, just like we have symptomatic physical conditions. And they said, but here's where we missed the boat. Not everybody who functions badly in life works like that. Other people malfunction in a way that looks like the thing in medicine we call a disorder. Now, the way an illness differs from a disorder is that an illness is acquired. An illness is something you get, something you have. You catch COVID. I caught COVID. I caught it before anyone knew what it was. I consider myself patient zero for Colorado because I came back from a trip on the coast last year in late January with a, quote, weird flu. And those of you who've heard me talk before, I'm a fitness fanatic. You know, I just had my physical last week and I score in the highest level in the 99% of fitness for people my age. And when I walked up a set of stairs with this flu, I couldn't breathe. I would be gasping for air and thinking, have I let myself go? And then, of course, I gave it to everyone I know, my wife, my best friend, his wife, my martial arts school. So I kind of patient zero, but it ran a course. Okay. And we all recovered and we're all fine and we're all vaccinated. So thank you, God. You know, what's interesting to me? Pam's symptoms are a little different from mine. You know, Tom Hanks and Rita Wilson, the actors, they caught it in Australia, and I had exactly the same course of symptoms he had, and Pam had exactly the same course of symptoms she had. So we know illnesses run a course. The difference is a disorder isn't caught. It isn't acquired. It's indigenous to the system. It is a system gone haywire. So notice when you have the flu, we don't say you have a flu disorder. And notice when you have diabetes, we don't say you caught diabetes, we say you developed a metabolic disorder. So disorders are developed and illnesses are acquired. And disorders don't have symptoms. Disorders have what are called characteristics. See, these were first called character disorders because they're characteristic, not symptomatic. We dropped that because we were afraid it sounded moralistic, and we're not trying to be moralistic, we're trying to be scientific. The difference between a symptom and a characteristic is a symptom causes trouble just by being there. I couldn't catch my breath when I had COVID. That was a problem. A characteristic isn't a problem of being there because it feels like you. It's that it makes trouble for you. So when you develop high blood pressure, that's not going to bother you. What's going to bother you is it causes a stroke or a heart attack. And characteristics in a disorder don't run a course. They're what are called pervasive and enduring. In other words, they stick around and they're all over the place. So the committee said what we figured out is that some people have psychological condition causing trouble that looks like an illness because it has symptoms that run a course, where other people seem to have a characteristic, pervasive and enduring pattern that doesn't bother them but causes trouble for themselves and others, like a disorder. And they said, this looks so different than any other thing we ever thought of that we're going to separate it into a separate category. And they called it Axis 2. And they said, you know what this looks like a disorder of? You know, it looks like it's out of whack over here. What it looks like is out of whack over here is the psychological system called the person. See, this over here on the left looks like what someone gets or has. This on the right looks like the way a person is. So we're going to call it a disorder of the system of the person, or a person disorder. Now, the name we use for how we experience the system of the person and other the system of the person and other human being is we call it their personality. So we're going to call this a disorder of the system of the person or a personality disorder. And they said, now we know why we failed with these people, because up until we did the science, everything we did was designed for symptoms. All the medications, the antidepressants, the anti-anxiety, the antipsychotics, they're all for symptoms. All of our psychotherapy, psychoanalysis, object relations, behavior, cognitive therapy for symptoms. And guess what? Symptomatic treatment doesn't work for characteristic problems. You can't treat diabetes with an antibiotic. So these people on the right are the people we didn't know how to think about and we couldn't help. And this is the distinction we were missing, because Freud didn't make the distinction, neither did Kraepelin. And they said, well, doggone it. Now we understand why. Everything we developed in mental health for the last 80 years has failed with these people on the right, because they have something wrong with how they are, not that they've gotten a symptom. So they said, cool, now let's come up with names for the different versions. And it took us about 10 years. And we have pretty well established there are 10 different types of personality disorders, and we have names for them. They're called things like paranoid, schizoid, schizotypal, borderline, antisocial, histrionic, narcissistic, avoidant, dependent, obsessive compulsive. So we have criteria for diagnosing them. They are consistent across planet Earth. We've studied other ones, passive aggressive, self-defeating, sadistic. They haven't held up well. And so over the last 3 diagnostic manuals, the DSM-3 in 1980, the DSM-4 in 1994, and the DSM-5 in 2013. And I was on the committee that revised the personality disorder section for DSM-5. I ran one of the research sites. We have established over 50 years that this is a valid, important condition. But the difficulty for you guys is it isn't going to show up as, quote, psychiatric, because they're asymptomatic. They're not going to look superficially like someone with a mental health condition. Now, what we've found, you guys, is that the personality disorders are so different from psychiatric symptomatic conditions that we had to change everything. And a whole almost cult-like group of us have gone into personality disorder work, and we have our own journals, our own experts, and your garden variety mental health clinician does not understand this stuff. So what we have found is this: what we call a psychiatric condition is a malfunction of the psychology or neurology of a person. For example, we know that depression is caused by a malfunction in the limbic system in the brain. There are things called 5-HT receptors that have to do with a neurotransmitter you've heard of called serotonin. They don't work right. And so we develop drugs that enhance serotonin to treat depression. It's a malfunction in the limbic system. We know that post-traumatic stress disorder, we call it disorder, but it's an illness, is caused by the amygdala and the hippocampus forming a loop. Francine Shapiro and a thing called EMDR figured this out, and we have to unhook that loop in their brain. We know that attention deficit is a screw up of the executive functions right here in the prefrontal orbital lobes that Russell Barkley has developed ways to moderate with the stimulant medications and the non-stimulants, et cetera. So we know that all of those are a crossed wire and a short circuit. A personality disorder, completely different. Let me draw it for you. Here's a personality. A normal personality is your toolkit for living life. And in it, your tools are called traits. So I'm going to draw a bunch of traits. Here's a trait, here's a trait, here's a trait. You have, those are your hammer, saws, and nails. And what your normal personality gives you is the flexibility to handle life's curves. There's a trait called introversion. It allows you to enjoy solitude and recovery. There's a trait called extroversion. It allows you to attach to people, connect. There's a trait called conscientiousness that allows you to be detailed and to be refined when you need to fill out your tax return and not get audited by the evil IRS. And a normal personality has enough traits in it to where you can be the different ways you need to be at different times. There's a place in Munich called the Max Planck Institute for Human Development. It's the largest research program on human development in the world. And they call personality your adaptive toolkit. Now, you don't have to be perfectly flexible or adaptive. You have to be adaptive enough. So when I'm doing psychotherapy with a patient, I'm in therapist mode. I'm making interpretations, drawing connections, looking at history. When I'm at home with my wife, Pam, I'm in husband mode. I don't treat her like a patient. Trust me, that would not go well. When I'm on a roller coaster, I'm in roller coaster mode, screaming and yelling. When I'm at a funeral, I'm in funeral mode. And I'm somber and reverent, you know? So you have all these different ways of being. Now, here's what we've discovered, you guys. In some human beings, as they're developing, that system fails. And they end up with only one way to be in their toolkit. And that's all they have. And they don't have another way to be. So it's not that they have a symptom. What's wrong with them is they're missing alternative ways to be. They're not flexible. They're not adaptive. The way they are isn't inappropriate when they're in a situation where it's appropriate, but it's inappropriate at other times. So we don't call these people sick. We call them inappropriate. Paranoid personality disorder means you have only one way to be. You're suspicious all the time of everyone. A therapist says, you can trust me. Someone with paranoid personality goes, why would they be saying that to me? Because they're always suspicious. Someone with dependent personality disorder is always submissive. They can't think for themselves. So you say, think for yourself, and they go, well, you have to tell me how to do that. I had a patient literally say to me, but what are the rules for making up my own rules? Pardon me? Narcissistic personality disorder are people who are self-confident, but they have no right to be self-confident. If you know what you're doing, self-confidence makes sense. But if you don't, you should be a beginner. But a narcissist is always grandiose and self-righteous. They're like, oh, I know it. I know everything. I know all about that. I had dinner with one, and I just was feeling evil. And something came up that said, oh, this thing happened. I go, oh, I know about that. And I knew they didn't. So I said, okay, tell me what. I was just being sadistic. They're like, I mean, they didn't have a way to say, I don't know. So what we found is that people with personality disorders are missing psychological pieces you take for granted. You know, people can be missing a foot. We know what narcissists are missing? Empathy. They don't know what it is. They don't have it. You know how people can miss a kidney? People with antisocial are missing honor and remorse. You know how you can be missing an eye? Well, some people are missing independence. And so we were shocked to find out that what this condition is these are incomplete people. You know, we have that phrase. People, we say, they're not all there. You know, it's true. So what we found was no wonder we weren't helping them, because we were trying to repair things that cause symptoms, where in these people, they're missing pieces that you and I take for granted. In the movie Collateral, Jamie Foxx plays an avoidant personality disorder cab driver who realizes he's driving around a psychopath played by Tom Cruise as a hitman on his hits. And he finally gets mad, and he looks in the rearview mirror and he says to Tom Cruise, what happened to you? You are missing pieces that are automatic for a human being. And that's a little action movie. Now, we found out after we started working successfully with these clients that there's something else missing too. You have an ability, and we have a name for that ability. We call it the ability to self-correct. Now, that you take for granted because it's automatic, but it's a high-level cognitive function. It requires a meta-observational position, self-objectification, self-awareness, self-control, and self-regulation. Our name for that in personality disorder work is your observing ego. So we draw it like an eyeball. You are watching yourself, and when you mess up, you do better next time. We found that whatever disables the growth of diverse traits, I'm not going to bore you with that, also disables observing ego. So to make the point it doesn't work, I'm going to draw a circle around it and put one of the European slashy things through it to show it doesn't work. Here's the key for you guys. Now pay attention. You are accustomed to talking to people who have an observing ego. You and their observing ego talk. You give them information and you expect them to be able to take the information and apply it to themselves. These people can't do it. The whole reason you fail with them is they don't have the self-observational function to take the brochures you give them, the videos you show them, the advice you present, and apply it to make good decisions. Not because they're missing the information, it's that they're missing the function to make use of the information. See, this is where you guys run into a brick wall. You want to give them the pamphlet. You want to show them the video. You want to tell them the data. Well, guess what? It's all correct, and it doesn't make any difference because they're missing the function you're expecting to take the information and go, oh, I get it. I need to have this child and make the world better. And they don't get it. It's not, there's no they in there to do the getting, okay? And what we found, you guys, is this dual deficiency of trait diversity and observing ego capacity changes their functioning to where they do screwy things over and over. John Livesey, who was one of the people who ran the committee Arizona for DSM-5, says it this way: a personality disorder is a human being who persists in a behavior in the face of clear evidence it's inappropriate and ongoing bad consequences. So you can tell that right now, I am having a conversation with your observing ego. You are taking in the data, the information I'm giving you, and you're going to think of how to apply it to your work. That's because you're not personality disordered, okay? But 39 to 100% of your clientele are. Now, here's what that means. You don't have to stop giving them information, but you have to talk to them in a way that bypasses the non-working observing ego in order to have an impact on what they're going to do. Okay, so this is the thing we found in mental health. We had to change everything. Even we were doing the work with symptomatic patients because it didn't work here. And so we developed models that are really good. They have weird names: dialectical behavior therapy, mentalization-based treatment, transference-focused psychotherapy, developmental object relations, blah, 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 blah. Forget it. I'm going to teach you techniques from those designed to help you have the point you're trying to make a difference to them, okay? Now, I've just taken you through 80 years of research, you guys. It took us forever to understand this stuff. Okay, so let me get on. Let me get my page up here. Hang on a second. My little thing isn't working. I've got some notes. I want to make sure I get you everything on my little, there we go. Oh, went to sleep. That's why. I have a little pad, electronic pad here. Okay, so the point is this. None of what you're doing will have an impact with this population unless you take into account that they're missing psychological structures you take for granted. Now, let me go through the techniques that we have found are really helpful here. Let me get a new page up. Okay. If you remember nothing else from this hour, I want you to remember this. So if you've been snoozing, if I put you to sleep, if the dog's been barking, you had to feed the cat, come back. I have a technique that is magic. It's going to sound really stupid, really basic. And when I read it in a book in 1988, one of the first books written on personality disorders, I thought, that's the dumbest darn thing I ever read. I started using it. This puppy has magic freaking powers. Remember this. When you're talking with someone who isn't getting it, if you begin to phrase what you tell them in a particular way, it's like a stealth bomber that flies through and hits them. And the technique is called SET, the search for extraterrestrials. I'm kidding. I'm married to a sci-fi junkie, so I make sci-fi jokes. What this stands for is you do a 3-part sentence, or it can be 3 sentences. The first thing you say is a positive statement about you, and that is called a statement of support. You say something supportive, okay? Here's the problem. If all you do is support, you're not going to make any difference. So the first thing you have to do is support, because if all you do is confront, you won't make any difference either. Then you make a positive statement about them called empathy. Okay, this is connecting with them. That opens the terrain to where you can hit them over the head with the hammer called the truth. S-E-T. And if you phrase everything you say to them with an S-E-T, you will be astonished at how it works. Here's an S-E-T. I want you guys to learn this technique. It's so powerful. You're really going to feel satisfied doing it. And this is what it sounds like. See, you didn't even hear it, did you? It goes right by you. I'm really glad you came to the center. I'm proud of you for facing this. And listen, I totally get how hard this decision is for you and what you're feeling. But you know, you want life to exist like I do. You see what that does? It kind of creates a territory that gives an opening for you to say the data, say the truth, and to bypass the yes buts and the defenses they're going to use because they only have one way to be. I had a man come to see me who was a very good man. He was a veterinarian of all things, and he was dating, and we were talking about some life history things he wanted to do. And he started dating a woman. I didn't like it because I was picking up personality disorder. And I told him he shouldn't get serious with her. So it was kind of, I laid down the gauntlet. Well, he quit. You know, he couldn't keep her in me. So yeah, I got killed off. 8 years later, he called me up and he said, he looked terrible. He said, my life's a disaster. You're the only one who knew this was trouble. You got to get me out of this. You know, that's one of those no good deed goes unpunished things. How do I get out of this? And I said, we'll try to say this to her. No, I said, you told her you want a divorce? No, she'll try to kill me. I mean, he said that. So I ended up describing SET and he said, yes, I get it. That'll work. So for 3 months, all I did was teach him everything he said to her as SET. This was a relationship that was darn near violent because of her. I tell you guys, I couldn't believe it. Smoothest divorce I've ever helped happen. And she was seriously disordered. I mean, catastrophically, dangerously disordered. No property rights. They had 3 kids, no custody battle. They had a lot of money. She was a physician. He was a veterinarian. And he came and he said, I can't believe it's gone this smoothly. Why does SET work with her? And I said, well, I can give you the theories. He goes, no, I don't care. Forget it. I'm just glad it does. I wish I'd known it 8 years ago. Thank you. Saved my life, which I didn't, but SET did. And I want to tell you, I got an email from him a little while back that said, dear Greg, I wanted to write you and tell you how I am. My second wife, he met a woman. He brought her in because he wanted me to evaluate her. She was wonderful. He said, we're married. We have 7 kids. They're grown. You got me started on this new life. It's now an old life, and I want you to know it's a wonderful life. And I want you guys to know that I hadn't spoken to him for 17 years. You know what did his life? SET. It was created by a psychologist named Jerry Kreisman out of the University of Missouri. I have used it with hundreds of personality disordered patients. And it works. I have never seen it fail, actually. Now, I'm sure it has, so don't, take my word for that. But if all you remember is a statement of support, you're well-meaning, a statement of empathy, they're well-meaning, the truth. The truth can be pretty rough, but it'll work. And there's a lot of room for, flexibility. You can do a whole bunch of support, a whole bunch of empathy, breathe truth. You can do a quick support, quick empathy, hard truth. Use it according to how you work. I'm reasonably confrontive. Personality disorder specialists, we're pretty rough. So I try to emphasize the support and the empathy because I'm pretty good at the hard truth. See what you think. But if you remember nothing else, SET is freaking genius, magic. created by God, designed for humans. I'm telling you, I don't believe it when I read it. And I won't tell you what book it's in because the book stinks. Number two, people make bad decisions because of what I call lack of sorting. Now, what I mean by lack of sorting is this population cannot tell something very fundamental things about life that come naturally for you. And here's the most important. They can't tell the difference between a thought, a feeling, and a behavior. And it's when you mix these three up that people make bad decisions. So a very, very powerful way for you to talk that will open the door for you to have an impact is to make sure that when they say something, you identify what they're referring to as a thought or feeling or behavior. Because a client will say this, well, I felt like I should have an abortion. That's not a feeling, that's a thought. So you say is, so you had the thought, I should have an abortion. Now, see, what that does is it constrains that to the thought area, and it opens up the other areas of life to be uncontaminated by it. Or they say, well, you know, I thought I had been bad. No, bad is a feeling. And so you say, oh, you felt bad. So you identify it as a feeling, and it puts it in its box and opens the rest of life. Or, you know, well, they were just enraged with me. No, they may have felt rage, but what did they actually do? Well, they yelled at me. Oh, so they yelled at you. And I thought that was bad. No, you felt bad. So they yelled at you and you felt bad. Yeah, and I felt like I couldn't take it. And you had that thought. So they yelled at you, you felt bad, and you had the thought, I can't take this. Do you see how that cleans up thinking, feeling, behaving? Now that I have it sorted and I have each of those in their realm, I can begin to talk about other things. But as long as that muddle process where they think feelings are thoughts and they experience thoughts as behaviors and they experience behaviors as feelings, you're not going to get anywhere because it's going to go into kind of a whirlpool. And this population lives in a whirlpool. We have a name for it. We call it drama. And we even have diagrams how it works. And to get out of that whirlpool, you have to get out of that whirlpool to talk in a way that makes a difference. So by sorting, that's a G, it doesn't look like one, make sure when you're talking, you say, oh, so you had the thought such and such. Oh, so you felt such and such. Okay. Oh, so they did such and such. You did such and such. I told them off. Well, now that's a thought, telling someone off. What did you actually say? So notice, you guys, I'm not telling you what to say here in terms of giving them data. I'm telling you a method to add on to the way you talk to give you opening to have an impact. Because listen, you got to move heaven and earth to have an impact with this population. The data show it takes in formal psychotherapy 6 sessions with them to reach the same outcome of 1 session with a patient with symptoms. So this is a big deal. So 2 techniques I've gone over with you so far. The genius magic, divinely inspired technique called SCT, support, empathy, and truth. And then the fundamental technique called sorting to make sure that everything's in its place so that you're talking outside of the whirlpool called the drama. Okay, so there's 2. Number 3, don't give advice, don't give information without first asking permission. Don't say, I'd like to give you this brochure. You bump right up against no observing ego. Say, so I want to ask if it's okay with you or if I give you a brochure about this. Say, well, listen, I have some advice. Would you like to hear it? My analyst will say to me, Greg, you want to know what went through my head when you said that? I had a patient who was borderline personality disorder in a therapy group, and she got mad at the group and said, when I bring up a problem, you guys give me solutions. I don't need solutions. I can come up with solutions. What I need from you is support and empathy and understanding. She was really mad. So she brought up a problem a couple of sessions later, and there was silence. And one of the group members said, I just put myself in your position, and I have a hard time with that. And she goes, now see, that's helping me. That's what I need. So say, can I give you some advice about that? Now, does it guarantee they'll take it? Of course not. Does it mean that it'll solve everything? Of course not. What it means is you won't bump up against the missing observing ego with the yes, but, the justification, the rationalization. And if they say, no, I don't want advice, don't give it because it wouldn't have worked anyway. I'll say, patient, you want to know what I think? They go, not really. Fine. Okay. Well, what else do you want to tell me? Okay. All right. We got a couple of last things, then we're going to do some questions if you've got some in the last 5 minutes. It's 12:52, so we've got 8 minutes left, and I promised not to run over. It's hard to shut me up, so I promised I would shut up. Okay, next. This population is on high defensive alert. Freud identified defense mechanisms as a way of staying right. And when people are afraid they're wrong, they get defensive. This population is always afraid they're wrong, so they have all these experiences where things don't work. So one of the things you need to do with this population is find ways to tell them they're right. They don't feel right. And they're coming to you in crisis, which makes it worse anyway. So find some ways to compliment. I'll say to a new client, I'm really glad you came in. What you're struggling with, you're struggling with this by yourself? That's hard. And it took guts to come sit in this office. People don't want to. People are embarrassed. People feel bad. And that tells me, what that tells me? You got guts. You know what that tells me? You can deal with this. We can work on this, because that's what that tells me about you. You can say to a client, I like the way you said that. You said that very well. Or good thought. That's a way to think. I like that. That fits. Find some ways to throw that in. Because if all you're doing is telling them you should make the decision I'm telling you to make and not the decision you're thinking about, bump right up against the lack of observing ego. So find some ways to compliment and tell them they're right. Make sure it's genuine. Don't lie. Find some ways. I don't care if you have to say, those are really attractive shoes. I really like those. I don't care what it is. Say something good, okay? Let me give you one last thing. Then we'll see if there's some questions. If not, I've got, another 6 hours I can give you. Let's see. Oh, yeah. Predicate matching. This one's helpful too. This one's pretty powerful. So people experience in language things in either as visual, can't spell. Let me redo that, I'm sorry. Visual, auditory, or physical. Listen to how they talk and use the same language. Some people are visual, they say, I don't see that. I don't see it happening that way. No, I can't picture that. Well, say that back to them. Well, I'll tell you how I see it. Would you like to know how I see it? Some people are auditory. They say, that doesn't sound right. No, I can't hear it that way. We'll say, well, let me tell you it this way. Some people are physical. I don't feel like that's true. I don't feel like it's that way. Say, well, you might feel like it's. So listen to what sensory channel they speak in, and it will tell you what sensory channel to speak back to them in. So listen to, they say, I hear that, I see that, I feel that. What do they emphasize? Okay. All right. So let me review real quick, and then we will see what questions you may have. So the things that are really applicable to you that I can teach you in this length of time to add on to what you do are phrasing things in an SET, sort, identifying thought, feelings, and behaviors as specific to put them in their realm so you have opening to make an impact. Make sure you ask permission, so because they're on high defensive alert, and ask permission before you give them something, because they don't have the observing ego to automatically take it in, and find ways to make them right, and listen for the predicates they use of which system they tend to operate most in, and be consistent with them. You know, when I saw a professional athlete, I was watching the Olympics, and I said, well, let's find a way that won't sideline you from this, that feels like you're out front. You know, I'm using these metaphors for how they experience. Okay. All right, good, you guys. Let me get rid of my whiteboard here. And anything you'd like to ask? We've got like 3 minutes left because, of course, I've run over. Anything? If not, I can reemphasize things. But if you'd like to, rock and roll.
Dr. Lester, someone asked if you could repeat SET, the SET example a little bit slower.
Oh, yeah, I do speak fast, don't I? Sure, you bet. So let me get SET up here, and I'll do a couple slower. Let me get back to my SET. Hang on. Okay. I think I'm really glad you're here today. I think it shows you have courage. And I think that means, you know, having this baby is the right thing to do. I really like the way you said that, because it says to me, you have good, clear thinking. You got a head on your shoulders, and you're going to be able to look at the things I tell you at the brochure I give you and know it's the truth and tell you what you should do. It works like that. See, the reason it's difficult to get is that it is so kind of, in a good way, slick, that it goes right by you. That's the whole method, is it slides right in. So I understand your desire to have examples. It means you want to use this well to have an impact with your clients. Do you see I just did it? You don't even see it, do you? And it just goes right by you. So yeah, I'm sorry I go so fast. I appreciate your request for me to do it in a more measured tone or speed. All right, we got a minute. Anything else I can do for you in a minute, you guys? Okay, so let me finish with this. Listen, thank you for the work you're doing, you guys. I hope that small piece I can add for you from what I do.
Dr. Lester, could I interrupt? We have one more question. If you don't mind.
Sure, of course. You can shut me
Brittany
up.
Green has it.
Hi,
Go ahead,
thanks
Brittany.
so much. So my question is, we saw during COVID, the type of client we were serving was drastically different than we had served before. So instead of seeing clients that were abortion minded, but they were much more open to making a life decision, we saw the clients, it was a dead hard stop. I want an abortion. Why are you not an abortion provider? Why am I here? Does this same technique work on them, or are we talking about a heart matter now at this point?
No. Now, that's such a good question for this reason. This population, when they're threatened, get more rigid because they only have one way to be. They cling to it. Let's face it, the COVID pandemic put everybody in crisis mode. So what you're seeing is an amplified version of the personality disorder where they're just stuck on this. And you can tell they don't have flexibility, they don't have adaptability, they don't have objective voice in their head. The answer to your question is absolutely these techniques help. Absolutely, they are what will chip away at that. No guarantees with any human being, of course, but your best shot with somebody that rigid is this, because when when a married couple comes in a crisis, they're as rigid about this kind of stuff as someone is about having an abortion. So we have designed our personality disorder work to work with the very thing you're talking about, the escalated, rigid, dramatic, absolutistic, not willing to consider, no observing ego, no openness. And you can tell the techniques I'm teaching you are to try to provide openings. With some people, you don't need that. They're open. You give them information, right? You know them, they're the ones you like. But you are right. This population's been terribly threatened with just the COVID going on, and it puts them into an excessively rigid and deficient state. So yes, try these with them. Try these with them, it helps.
Can you give us like one really good example, like a sample statement of someone who in that type of rigidity is like, no, I'm going to kill my baby. Where do I go?
Okay, so your thought is, I'm gonna go kill my baby. I get it. How's that feel? So notice what I did. I just put the thought into, oh, that's the thought. Now I'm gonna go to another realm that isn't addressed because they're describing that as they're feeling and it isn't. So I'm gonna say, well, how's that feel? And they're gonna say, see, you don't know what they're gonna say. That's what you want. What you want is for them to not know what to say, because now you've got an opening where they're not certain. So by sorting that I'm going to kill my baby into, okay, so your thought is I'm going to have an abortion. I get it. I get I get that thought. I get that. Now, what does that feel like? Now, and then you're going to go elsewhere because you're going to put that in its cage and you're going to go over here. Or you can say, use an SCT. I'm glad you're thinking about what to do with this pregnancy. I can see this is really hard for you. But I think that may be a premature conclusion. See what that does? Softens up the territory. It's kind of, I'm going to use a terrible analogy. It's calling in an airstrike to clean out some of the defenses before you send in your soldiers in the war. Remember, you guys, remember something. A clinical conversation is not an advocacy conversation. If you advocate with this clientele, you might as well not bother talking to them because they're oppositional, they're defiant, they're rigid, they're unreasonable. So you do not add clinical conversation, may have the same purpose as advocacy, but it doesn't have the same method as advocacy. And what you're trying to do here is make an opening. So yeah, try these with that population. Excellent question. I appreciate that.
I already feel decompressed by it.
Okay. I mean, isn't it interesting just in our little example how it feels when I do it? Just example. What you can feel what it does in your head, can't you? Isn't it something? And it only took us 80 years to figure this stuff out.
Dr.
All right, well, I'm going to let you guys go.
One quick one. This one's very quick.
We'll do a quick one.
It came in on the chat function. Do you have a
Okay.
recommendation for where there's a marriage with a narcissist for a therapist in LA that might be able to deal with that?
Okay, so personality disorder is a pretty distinct subset. So I have, no, I don't know anyone personally, so I'll tell you how to find someone. Call up UCLA in their psychiatry department at the hospital and ask for someone who's good with personality disorders. Medical schools usually have a department that has somebody that's good at it. The second thing you can do is the Mecca, kind of the Vatican for personality disorders is called the Menninger Institute. It's in Houston as part of Baylor Medical School. Call them up and say, who do you know in LA who's good with personality disorders? Because they wrote the book on personality disorders. They did the first study in 1966. So go to UCLA and say who you got, or call up Menninger and say who you got. Because you don't want a garden variety clinician for this, you guys. It will fail.
Okay.
So good question.
Thank
All right,
you,
so you guys,
John.
I'm going to check out and let Dan here finish with you. Thank you for having me. It's always a delight and a joy. I hope it's been helpful. We'll see you again next time. I'll let you go. Bye-bye.
Bye-bye. All right. So Dr. Lester is signed off, but nevertheless, I thank him. It was, I thought, a very useful and very informative presentation. I'm going to offer, before we close, a short closing prayer. In the name of the Father, and of the Son, and of the Holy Spirit, amen. Having heard Dr. Lester's presentation, we renew the prayer that we made at the outset. Grant that it assist us in furthering our efforts to defend and protect your creation, Lord, and to defend all that is good and in accord with your plan for your creation. Grant in particular that it that it assists us in understanding, loving, and helping persons with personality disorder. We ask this through Christ our Lord. Amen. In the Father, and the Son, and the Holy Spirit. Okay, so before we leave, let me announce our next presentation. We have Tom Glessner of NIFLA, the National Institute of Family and Life Advocates. I think most or probably all of you are familiar with NIFLA. NIFLA was the plaintiff in a previous Supreme Court case concerning the posting of abortion advocacy outside pro-life counseling centers, the Becerra case, which was successful in the Supreme Court. Tom will present on September 1st, the first Wednesday of next month, on the topic of the Supreme Court case that is up now in the Supreme Court, the Dobbs case, in which the state of Mississippi is challenging Roe v. Wade. And Tom's presentation will be the Mississippi case and the inevitable demise of Roe versus Wade. So that, of course, is of gargantuan interest to everyone. And I hope you can join us. You and others who have previously participated in our programs will receive an email invitation. And I hope that you can join us then. So again, thank you everyone for participating, and I hope to see you again next month on Wednesday the 1st for Tom Glessner's presentation. Thank you very much.
Thank you, Dan. Thank you, Jacob. And thank you, Rosie.
Thank you, everyone, for joining.
Blessings to all.